Okay, good afternoon, everyone. How's everybody doing? Hope you guys are all doing okay. So if you guys can turn on your videos so I can see that you're there. Jaslyn, there you go. All right, perfect. All right, your exam one. Your exam one was okay. Your exam one was okay. Nobody aced it. But I think everybody did skew to a favorable score. Everybody did okay. One thing that you need to know is that or need to remember, and I said this a few times, if I give you guys a reminder, or if I give you guys a tip, you guys need to listen to the words that I say. I said, make sure you memorize normal values. Okay, nobody aced the normal value. Maybe one person aced the normal value portion of the exam. And I was kind of disappointed. Normal values are a given. Um, that was on the back page where the ranges were supposed to be written down. And also too, some people missed the L's and the H's. Um, there was one, there was one, there was one question that I had given. I hope that you guys would have picked up when I said there's going to be calculations and the two words as appropriate was included. And that should have put up a flag. What does he mean by as appropriate? If he gives a calculation question, I'm just going to go ahead and calculate it, right? Well, not all the time you'll need to do a calculation. So there was one question where I know everybody calculated the corrected WBCs for the NRBCs. And can somebody tell me what the cutoff is in doing the calculation? If it's 10 or greater, then you do the calculation. So I gave you one where the NRBCs was 7. So the correct answer was NA. Okay. So that should have raised some kind of question. Usually, all the way back into like second or third grade, when they give you a math problem, you'll calculate it. But then, and you got calculations, but then when calculations are easy to do, and everybody just jumped on it and did the calculations. But then when I say as appropriate, that you guys should have said, well, what does he mean by as appropriate? I mean, okay, so that means there's a condition where you would not calculate it. And then you would have to think back into the lectures and find out that, oh yeah, if it's less than 10, then you don't need to correct. Okay, so things like that. I'll throw hints at you. So normal values, I said, make sure you know normal values, make sure you know the formulas, and the formulas for the indices, and that was given on the in the exam. So formulas are given. So I told you guys, make sure you know the formulas. The absolute counts, I think you guys did okay. Ferritin versus transferrin, some people I think were still confused. Ferritin is storage and transferrin, just like where the word says transfer. Transfer iron from the reticular endothelial system to the erythroid marrow. So transferrin, transfer. And ferritin is just plain storage. The true false, and this is what I was saying, make sure you read the questions. Make sure you read the questions and you understand. Okay, so here's a question. It says, in negative iron balance, the ability to absorb iron from the diet will exceed the demands or loss of iron due to pregnancy, growth spurts, and poor diet. So what is that? What does that translate to? That means the amount of iron that you're absorbing is more than the loss, which means that If you have more iron that you've absorbed into your body, and that's more than the amount of iron you're being lost, are you at an excess or are you at a deficit?
Excess.
You're at an excess because the ability to absorb iron from the diet will exceed the demands or loss. So the ability to absorb iron, that means the iron that you're taking in is more than the amount of iron that you're losing. That means you're still in good shape. So does that result in a negative iron balance? The answer was false. Okay. By the way, all the true false questions were all false. Let's see. Okay, here's another one that if you would have picked up from reading. It is normal to find macrocytes in the peripheral blood. I mean, sometimes you'll find macrocytes. These macrocytes are actually reticulocytes. They're actually reticulocytes and are polychromatophilic when seen in new methylene blue. Well, when they're polychromatophils, what stain are you looking at? I know I mentioned reticulocytes, and then at the end, I put new methylene blue, but then I said, and are polychromatophilic when seen in new methylene blue. So that one's false. It's polychromatophilic when it's seen in right stain. Okay, so that one was false. And then this should have been an easy one. I think more than half of you got, or almost all of you got it. It's, remember the trick I told you, ferric iron is bound to oxygen to be delivered directly to the tissues, right? Remember the trick I told you? Ferric doesn't have an O, but ferrous has an O. Okay, so the O with the O, so that one was false. So you'll get these exams on actually, you won't get it until next week. That's why I sent you guys the key. You guys saw the key, right? And hopefully you realized what your mistakes were. Like I said, the calculation for absolute counts for height. The rule of threes. If I gave you a hematocrit of 42, you should have been able to, and I think most of you did, you should have been able to estimate what the hemoglobin is. And the answer to that was 42 divided by 3, or 14. And then I said this a lot of times because, and I mentioned that iron deficiency anemia is like one of my favorite anemias, because if I see it on a smear, I'll say, wow, this is immediately iron deficiency anemia. So everything is low because it's an anemia. The RBC markers, RBC, hemoglobin, hematocrit are low, and the MCV as an RBC marker, it's low. But there's only two things that are increased. One of them is RDW. It's RDW is increased in iron deficiency anemia, and the other one, it's not a CBC parameter, but it's retic count. Retic count is increased because it's compensating for the anemia. So, like I said, you guys did good. You shouldn't be discouraged. You shouldn't be discouraged. But I think you all did fairly well. Did fairly well. So tomorrow you have quizzes on lecture 6 and 7, aplastic anemia and hemolytic anemia. Does anybody have any questions on any of those two lectures? Does anybody have any questions on, for example, allo versus auto? Anybody need any clarification on that?
Yeah, sure. Can you go over that?
Yeah, allo antibody versus auto antibody. Okay, so allo antibody is a little bit more, the concept is a little bit more simple, okay, because if you're exposed to something external, like a transfusion, usually alloantibodies are come about when you receive a transfusion, Why? Because if you don't have an antigen, for example, whether it be the D antigen or the Kell, Kid, Duffy, you can, whatever, antigen on your red blood cell. If you don't have it, the first time you're exposed to blood, and usually when you're exposed to an antigen, it's usually through a blood transfusion. So you're going to be exposed an external source through a blood transfusion, blood that has that antigen that you don't have. So when you get that blood that has an antigen that you don't have, your body's going to react to it. Okay, your body's going to react to it. It's going to, let's take Kell, for example, the Kell antigen. You don't have the Kell antigen. Okay, so you need a blood transfusion, and the unit that you're going to get has the Kell antigen. Okay, so what happens is your body says, oh, there's Kell antigen. I don't like you because you're foreign and I don't have the Kell antigen. Therefore, I'm going to make anti-Kell antibodies. Okay, anti-Kell antibodies. Okay, so now you have anti-Kell antibodies. The next time around, so you develop, that's actually that's called sensitization. You're going to learn all this in blood bank. When you're exposed to something and you make antibodies to it, that's called sensitization. So when you get exposed and sensitized to an antigen and you develop antibodies to a specific antigen, then you develop antibodies. Your body is reacting and it produces antibodies. So what happens the next time around, if you get a Kell unit of blood and you have anti-Kell antibodies, you're going to get a bad reaction because you're anti-Kell. And my rule is the first one's free. If somebody makes a mistake as a lab manager and they come to me and they make a mistake, I'll tell them first one's free, but the next one you'll have to pay. Well, same thing happens with antibodies. Your first exposure is free. You're not going to react to it, but what happens is you create antibodies. You make antibodies. So the next time around, you get a unit of blood and it has Kell antigen on it. You're now armed. You're now armed with anti-Kell antibodies, and you're prepared when that unit of blood and that antigen comes into your body. You're going to react to it, and it's called a hemolytic transfusion reaction, and that's bad. Okay, and that's why in the blood bank you do screens to find out what kind of antibodies you got. The hemolytic disease of the newborn, it's the same concept. The mother does not have the antibody. She's Rh negative. Okay, she's Rh negative. Okay, so and this is pretty serious, especially for OB, because the first time that she delivers a baby who's Rh positive, she'll develop anti-D antibodies. The antigen is D. So if you're Rh positive, you have the D antigen. So if you get a transfusion, she gets a transfusion, she doesn't have the D antigen, but her body sees the D antigen, therefore she'll react just like the Kell and make anti-D antibodies. Okay, so the second time around, and this is the second time around when she is pregnant and the baby is Rh positive, her husband's Rh positive. Now, after the first baby, because the baby was positive and she made anti-D antibodies, the second time around, it's not going to be a transfusion reaction. Those antibodies that she made against the D antigen are going to attack the baby in utero. Okay, and that's what causes the erythroblastosis fetalis. So what happens is, so what does that mean? Any mother who's Rh negative can't have babies? No, that's why they have this product called RhoGAM. Rho, it stands for D, and GAM is gamma globulin. So what it is, it's a shot that women get when they're pregnant. I think it's during the first trimester. If they know that if they're Rh negative and the husband's Rh positive, there's going to be a possibility that the baby's going to be Rh positive. So what the key to that is, you do not want the mother to make antibodies herself, make antibodies against the baby. So what you do is you give ROGAM, your body will say, okay, I need to make antibodies. Well, I don't need to make antibodies because I got this anti-D antibodies already. Okay, the dose of the ROGAM is not going to be enough that it's going to hurt the baby. But what it'll do is it'll fake the mother out, and the mother will not make anti-D antibodies. So ROGAM will save the baby's life. Are you guys clear on that? Pretty easy. So when you guys do blood bank, it'll be pretty easy. So that's allo. That's allo antibodies. Autoantibodies are antibodies against yourself. Okay, so anti-I is another antibody. Anti-I is like, for example, paroxysmal cold. Let's take paroxysmal cold antibodies. Okay, not hemoglobinuria, PCH. So what happens is, and it happens in children, and the way you can tell, this is another trip. PCH, C for child. Okay, C for child. So in children. So what happens is, a child will develop a viral infection, and usually after a viral infection, they will develop an antibody, and it's called the Donat-Landsteiner antibody. Okay, so these antibodies will bind a complement. Okay, so and then when the complement is released, when it goes to the core, then it will attach, it'll attack normal red blood cells. Okay, so what happens is, after a viral infection, the red blood cells are lacking a protein. And what happens is, complement will actually, and this is in PNH now, PNH. I shouldn't confuse, because PCH, you got PCH and PNH, but PCH, you got the Donat-Landsteiner antibody. You just have the antibody and it'll attack red blood cells. PNH, that's the one where it's congenital, where your red blood cells are missing a protein. They're missing a protein, and what happens is, when at nighttime, and that's why it's nocturnal. At nighttime, complement will see these damaged red blood cells because it's missing a protein. So it's kind of like autoimmune. This is complement, where complement in your body is attacking these red blood cells. What happens is, complement will bind these bad damaged red blood cells and it happens at night, because that's when your immune system is active, and that's why in the morning you're urinating orange or reddish orange urine. In the PCH, that's when you develop an antibody, and that's with the Donat-Landsteiner antibody. So PCH is for paroxysmal cold hemoglobinuria. Anti-I is the cold agglutinin. Anti-I is in your body, and anti-I will attach to red blood cells and cause red blood cells to agglutinate at cold temperatures. And that's why when they attach to the red blood cells at cold temperatures, then that's why you'll get errors on when you run the specimen through the hematology, and that's why you have to pre-warm the sample. Cold agglutinins, you have to pre-warm the sample. Okay. So that's auto. You have antibodies or reactions against your own self. That's auto. Now, those are cold. In the blood bank, I don't want to get too much deep into the blood bank. When you have antibodies that are cold, they're not really clinically significant, because your body's not cold. Your body is 37 degrees. And these antibodies they're pretty active at room temperature or cold temperatures. So if you have a cold autoimmune, no big deal, because your temperature is 37. But if you have a warm, then you have to find out what the antibody is, and then it's a warm auto. And I never had a warm auto antibody in the blood bank, but I know a blood banker who was pretty sharp, spent almost a whole day in trying to figure out what units are compatible. So you'll get all of this in the blood bank. So that's auto. Okay. And then for PNH, you know, the two tests, right? Screening versus confirmation. What's the screening test?
Sucrose hemolytic test.
Yeah, sucrose hemolysis test. And then the confirmation
AMS test.
AMS test. Okay. What about hereditary spherocytosis? What test would you use to diagnose that?
Osmotic
Osmotic
fragility.
fragility.
Okay, it seems like you're pretty prepared. We have time after my 2 lectures, then we'll do some more review for quizzes 6 and 7 that which you'll be getting tomorrow. There's one thing about now you're supposed to be getting exam 2 next week, correct? According to your schedule. But what I kind of didn't want to give you quiz, what is it, 8 and 9, the same time I'm going to give you exam 5 through 9. So I'm kind of I want to push it off until the following week. Would you have any objections to doing that, for me doing that? It'll give me another week. It'll give me a week next week to review some more for the exam. Because the exam next time, for exam 2, it's going to have, I'm thinking about adding a couple bonus questions. And the bonus questions will be like case studies where you'll have to figure out what's going on, have to figure out what type of hemoglobin is present, things like that. And they will be bonus questions. And also too, in addition to the multiple choice format, I've got matching, okay? There's going to be a matching portion on the exam 2. So that's why, since if I gave you exam 2 next week, then you'll have 2 weeks without an exam. So if I give you exam 2 in 2 weeks, then you'll have 1 week free, and then you'll have exam 3 following. Okay, because exam 3 will go over troubleshooting. I don't think it's going to be that extensive. Would that be a problem? Also, too, you guys had a chemistry test recently around the time when I gave you the exam 1, correct?
I don't think it was chemistry, but it was, I think it was your analysis. We had it on the same day.
You had your analysis around the same time as
Yeah.
And immunology a day before or after?
it was a day before. So, like I said on our first meeting, if you guys have exams like that and you want to consider moving an exam around, I can find leeway so that you can reapportion your study time, you know, okay? So with me pushing exam 2 1 more week, will that cause any conflicts with anybody? If not, you get exam 2 next week. Because what I'm planning on doing is doing a review for exam 2 next week.
Sounds good.
You okay with that? You don't have any exams that'll conflict? You guys are being pretty quiet.
I'm going through my syllabus right now of the other classes.
Okay,
Just to clarify, you wanted to push exam 2 to
week.
the week following, so on the 7th, October 7th?
Yeah. Would that be okay? You don't have any exams on or around that time, do you? My main concern is chemistry. Chemistry, usually from other classes, they said, well, we have a chemistry class, we have a chemistry test the week before. So, I mean, the day before. And what happens is then after their chemistry test, which is the night before now, then they're studying for their hematology. I don't want to do that. I want to give you more time to study for hematology. If you have a midterm exam that'll conflict with your studying. So push it off 1 week. Is that all right?
That's all right with me.
That's fine.
I'm fine with that.
Okay.
That should be,
No conflicts. I'll take that as a yes, and then I'll push it. Okay, so I'm gonna now do megaloblastic anemia. If there are no questions, like I said, the exam one wasn't too bad, and I think you'll do fine. I don't, you shouldn't be discouraged. If you need any help or anything, please ask questions or send me an email. If you need extra help or anything like that, send me an email and I'll be happy to clarify that with you. If I have to do Zoom, then I'll do Zoom. But please let me know. I want you guys to, my job is to teach you hematology. I want you guys coming out of this class practically knowing almost as much hematology as I know, okay? And I picked up a lot of hematology in my years of experience in the laboratory. So I want to share that with you. All right. So megaloblastic anemia, megaloblastic big. So you guys should know already, what are the two anemias that are classified in megaloblastic anemia? Oh my God, it's right there. Anyway, B12 and folate. Also too, and I did mention this, but B12 and folate deficiency causes pernicious anemia. So just to get the terminology straight, like for example, and I'll get into this, if you have a parasitic infection, a worm in your gut, what happens is that worm will compete with you in getting the vitamin B12. So you eat your meat, you get you think you're getting vitamin B12 out of the food that you eat, but what's happening is that worm will intercept the vitamin B12 and cause you to be B12 deficient and create pernicious anemia. So things like that. But pernicious anemia is the actual anemia. The deficiency is B12 and folic acid. So in this type of anemia, it's caused by an abnormality of DNA synthesis. And I'm going to it's an interesting problem with DNA, and I'll talk about that later. And the most common cause of the megaloblastic anemia is a deficiency. And the cause is a deficiency in those two vitamins, vitamin B12 and folic acid. So so when you run a test, it's a combination of B12, it's called B12 folate. As you know, folate is the conjugate base of the acid folic acid. I hope you guys all know that. So if you see acetate, acetate is the conjugate base of the acid acetic acid. Okay, benzoate, for example, I know you've seen that. That's the conjugate base of the acid benzoic acid. So anything that you see that ends in ate, then there's an acid that's involved with it. Okay, so folate or folic acid. In the bone marrow, what the pathologist will see in a person with megaloblastic anemia are megaloblasts. And these are large abnormal red cell precursors in the marrow. So the problem with megaloblastic anemia is it's starting in the bone marrow. Okay, so there's ineffective erythropoiesis and there's intravascular hemolysis. Intravascular hemolysis means that it's within the red blood cells. If it was within the actual cell, then they would be intracorpuscular. But intravascular means it's within the blood vessels, okay, hemolysis. And it's defective nuclear maturation caused by the impaired DNA synthesis. So in the marrow, you have erythroid hyperplasia, so that the ME ratio is 1:1, myeloid to erythroid, okay, myeloid precursors to erythroid precursors. Now that's abnormal because the normal ME ratio or the myeloid erythroid ratio is 3:1 to 5:1. There's 3 times more myeloid precursors than erythroid. Okay, so myeloid includes the platelet precursors, the neutrophil, the myeloid cells, and then also to the lymphoid. And then obviously the erythroid would be the erythroid precursors. I think I sent you guys, okay. I sent you this, where it's the maturation sequence of the 3 cell types. So for the granulocytes, you know, it starts, these are the precursors starting, and you're gonna know this when we do WBCs, myeloblast, promyelocyte, metamyelocyte, and bands. So those are the precursors, okay? And then these cells are normally, the cutoff is here, just like in the red blood cells, the cutoff here is everything before this is bone marrow, and everything out here is the granulocyte. And the same thing for monocytes. Everything before here is in the bone marrow, and everything after is in the peripheral blood, except for macrophages, they're in the tissue. And then the next one would be lymphoid. Okay, everything before the lymphocyte, everything before that is in the bone marrow, and the lymphocyte and the plasma cells are outside the bone marrow. There's another one here. Yeah, this one. Okay, so you got megakaryoblast. Anything that's megakaryo, if you see megakaryo, megakaryo refers to platelets, okay, like the megakaryocyte, megakaryoblast. Megakaryo anything is platelet. And then erythro is obviously red cell precursors. Myeloid, if you see myeloid, those are the myeloid series, okay? Myeloid meaning that starting with myeloblast, and then it goes to and these are the matures, the eosinophil, basophil, and neutrophil. Again, we're gonna go over this when we do the white blood cells. And then the monocytes. And then you got your lymphocytes here, lymphoblasts, and the mature lymphocyte. So you got your myeloid and the lymphocytes. These are all considered myeloid, okay, because it's white blood cell, nucleated. And then you have your red cell precursors. You notice there's no red cells here. So the ME ratio, that's why, you know, I know you know that the red cell normal value is times 10 to the 9, and the WBC is times 10 to the 3rd. Well, that's why the ME ratio in the bone marrow, it's usually 3 to 1. It's more myeloid than erythroid because it includes all these precursors. Okay, so normally it's 3 to 1, 3 to 1 or 5 to 1. But in megaloblastic anemia, it's erythroid hyperplasia. So the erythroid hyper, meaning it's more active, so there's more proliferation of RBC precursors, that it catches up with the myeloid. So it becomes 1 to 1, okay? And then the megaloblasts are large with delicate chromatin, and that's an RBC precursor, okay? It's not myeloid. Megaloblast refers to, that's why you have a large red blood cells. So what happens with the defect in B12 folate deficiency is that when you have a person with B12 folate deficiency, the nucleus and the RBC precursors, the nucleus and the cytoplasm normally will grow and develop at the same rate. Okay, they'll grow and develop at the same rate. But in vitamin B12 deficiency, the problem is you have what's called nuclear cytoplasm asynchrony, where the nucleus and the cytoplasm do not develop at the same time. That's why actually it's probably the nucleus develops faster. The nucleus develops faster than the cytoplasm, and I'll prove that to you. So there's an asynchrony, and that's what causes the problem in the DNA synthesis. Okay, so remember that NC asynchrony, nuclear cytoplasm asynchrony, where the nucleus and the cytoplasm do not develop at the same time. So one way to see that this asynchrony is, let me go back to this chart. It's not here. Let me see if I can see it. Okay, so you go from band to granulocyte, okay? But I don't like this term granulocyte. This is actually supposed to be neutrophil, okay? a granulocyte is a cell that has granules, but the term for the mature cell on the myeloid series is neutrophil. Okay, is neutrophil. So what happens is, so here are the neutrophils right here. Okay, neutrophils. Usually the lobes on the neutrophil in the nucleus is 5 or less. 5 is kind of a lot. Usually it's 3 or 4 lobes. Okay, lobes meaning it's the nucleus is segmented off. This is the basophil with the dark granules and eosinophil with the red granules. Okay, so usually it's 3 to 5. In megaloblastic anemia or in vitamin B12 deficiency, the nucleus has developed more, or it's called a right shift, where you have hypersegmentation, where now you have 6 or more lobes in the segmented neutrophils. You have more development. So that's kind of like proof that of this nuclear cytoplasm asynchrony, the nucleus has developed faster and actually has gone into creating more lobes than normal. Remember, normal would be 5 or less. Usually it's 3 or 4. Now in vitamin B12 deficiency, we have segmented neutrophils, and you will see segmented neutrophils, and that's diagnostic of vitamin B12 deficiency. You'll also see ovomacrocytes. The MCV in vitamin B12 deficiency is big. Okay, so those are the 2 main identifying factors in vitamin B12 deficiency or megaloblastic anemia. So the number of hypersegmented neutrophils per 100. So when you do your differential, you'll count your differentials, but if you notice that there are hypersegmented neutrophils, that's reportable. So you'll count them as diffs, but then off to the side, you'll also make a mental note. I saw 1, I saw 2, I saw 3. You'll get to do that when you do differentials, which is your last exercise, hopefully in the lab. Okay, aniso and POIC may also be present. Now, I've been telling you aniso and POIC, if you see aniso and POIC high RDW, that's iron deficiency. So aniso and POIC is present in a lot of conditions, but a lot of aniso and a lot of POIC is iron deficiency anemia. So aniso and POIC are present, may also be present. How jolly bodies and cabin rings may be present in B12 folate deficiency. So the cells are larger. Myeloid precursors, the metamyelocyte, that's right before the band, and then you got your band. So one of the terms that I want to introduce, and I think I may have mentioned it to you, is a left shift. Okay, so this is normal. This is the normal cell that you'll see in the peripheral blood. This is the boundary: peripheral blood, bone marrow. Okay, peripheral blood here, and bone marrow cells there. So if you notice that, if you go in, and it's good that the arrow is going in that direction because that's the direction of development. So if you go in the opposite direction, like towards the left, so if you go left, it's band. If you go more left, it's metamyelocyte. Go more left, it's myelocyte. That's what's called a left shift. Usually, if you have, and I've seen this, if you have a lot of bands, for example, normally you'll have neutrophils. And you know that normal value for neutrophils is, right? It's in the 60s. But then if you see a lot of bands, okay, increased bands is a sign of infection. It's one of the signs for infection, and I'll go over this when I do WBCs in the myeloid series. But if you see a lot of bands, that's a good indicator for infection. And I saw this, it was like white count was greater than 10, I think it was 13 or 14. But oh my God, the bands, they were all over the place on the differential. It's not a reverse diff, but it's a sign of infection when you see bands. So you go from here to here, that's a left shift. Okay, if I say left shift, that means you're going to the next, or you're going to the previous stage of immaturity. Okay, so for example, you already encountered a little bit of it, the normal red blood cell, right? Using that terminology, what would be a left shift to a normal red blood cell? what was this? What would be the next cell? Or the cell? Say again.
Retic?
Correct. So we don't use left shift for the presence of reticulocytes, but it's the same. It's the same principle. It's the same principle. Usually, the term left shift, if you tell a doctor, an ER doctor says, "I'm seeing a left shift," he's gonna want to know that term, and he's gonna want to panic, and he's gonna be happy because he knows what's going on with the patient. Patient has an infection, especially if he's suspecting appendicitis or something. Okay, now on the other end, if you go towards, and it's not illustrated here, the hypersegmented neutrophil, that's called a right shift. The stage after the granulocyte is a hypersegmented neutrophil. That's where you have 6 or more lobes. So hypersegmentation is called a right. Another term for that is right shift or hypersegmented neutrophils. Okay, so now you got left shift and right shift down. So the cells are larger, metamyelocyte and band. So B12 and folic acid deficiencies can lead to decreased thymidine levels and defective DNA synthesis. Clinical findings of B12 folate deficiency, mild to severe anemia. So when I say that a patient is anemic, anemia refers to the red cell markers, which are RBC, hemoglobin, hematocrit, and MCV. Don't say anemia. Well, okay, that means it's an increased WBC. Anemia has nothing to do with WBC. That's your WBC is infection. Remember, it's viral infection, bacterial infection, or leukemia. That's WBC. If I say anemia, it's your red cell markers, your RBC, hemoglobin, hematocrit, and MCV. Okay, and the indices, but the indices are those are calculated. Okay, so you'll see weakness, fatigue, shortness of breath. Okay, again, anemia, red cell. You got that all correct on your homework, by the way. And jaundice due to intramedullary hemolysis. Okay, so if you take a term like intramedullary, can you guys figure out what that means? What does intra mean?
Inside.
Inside or within, correct. Inside or within. What's medullary?
Medulla.
Medulla, the medulla of the bone, right? And what's so the opposite of medulla is what?
Outside the bone.
The outside of the bone, or called
Cortex.
cortex. So you got the medulla and your cortex. So intramedullary means within the bone marrow. Okay. So I don't know what the cell is, but it's an NRBC. It's a nucleated red blood cell. But also too, you get all these large egg-shaped cells. Those are megaloblasts. Okay. I'm sorry, those are not megaloblasts. Those are oval macrocytes. Oval macrocytes. They're macrocytes. They're RBCs. They're RBCs, kind of like normal central pallor, but they're big. Okay, those are oval macrocytes. I'm sorry, I didn't mean to say megaloblast because megaloblasts are in the bone marrow. This is an NRBC. I don't know if it is. It says here it's a megalorubrocyte. So when you do the maturation sequences, you'll need to know the monocytic series, the myeloid series, but not the RBC series. Okay. So like I said, I don't know what that is, but it's in NRBC or nucleated red blood cell. So here's a printout, as you can see, and this is typical for vitamin B12 deficiency. As you can see, anemia, look at the red blood cell. It's 2.61. Hemoglobin, it's low, 9.8. Hematocrit, 26.3. But look at the MCV, it's 108. So your RBC markers are low. Don't say that this is and RDW is high. Don't say, oh, it's anemia and RDW is high. Well, that's not really too high. Usually iron deficiency is in the 20s. So, but the thing that you should take note of is the MCV, because, and also too, in iron deficiency anemia, what type of anemia is iron deficiency anemia?
Microcytic, hypochromic microcytic.
It's hypomicro, exactly. So is that the MCV of a hypomicrocytic anemia? No, it's anemia, but it's megaloblastic. So megaloblastic anemia. That's the type of anemia it is. Vitamin B12 folate deficiency is a megaloblastic anemia. Iron deficiency anemia and thalassemia are hypochromic microcytic anemias. So that's what this printout will show. So you may be getting a printout, and that's why you should be able to figure out what the heck is going on. This is hypersegmented neutrophil. See how there's a lot of lobes there? Again, evidence of the nuclear cytoplasm asynchrony. Looks like the nucleus continued on in development and created more lobes. So that's evidence of the nuclear cytoplasm asynchrony. Right shift, hypersegmented neutrophils, okay? Oval macrocytes, I guess this one, I don't know, maybe these two. The thing that to me is striking about this slide is the hypersegmented neutrophil. But these three cells maybe are the high MCV cells. More hypersegmented neutrophil, definitely more 6 or more lobes. So this is what will happen when you go too far deep in. So what's going on here? What does that look like to you?
Rouleau formation.
Yeah, it looks like rouleau, but guess what? It's not rouleau. This is what happens when you're going to be getting your slide boxes of your WBCs or even your RBCs. If you see this, that means you went too far deep in. So you have the feathered edge, and then you're supposed to do your scan, and Xavier will tell you this. You do your scan next to the tip of the feather, but if you go too far deep in, all the cells are going to look like rouleau formation, and you say, oh my God, this person has Waldenstrom's. Said, no, look at where you're at. You're too far deep in. This is what you'll see. You'll see a lot of rouleau, but it's not rouleau. You're just too far deep in. So for this slide, it's hypersegmented neutrophils, a lot of cells. So megaloblastic anemia, normochromic, meaning normal central pallor, and macrocytic, meaning large cells. This patient's anemic, so in significant B12 folate deficiency, a hemoglobin of 7 is pretty low, but MCV is definitely greater than 100. Wow, sometimes as high as 160. I've never seen that. Usually babies have that type of, babies have big cells, but also too, be suspicious. If you see an MCV that high and you're thinking artifact, because other things can cause MCVs to be that high as an artifact. You remember what a couple of them are? Like a clotted sample or platelet clumping or RBC agglutination. Those can give you super high MCVs because the cells are clumped together, and those clumps as a group are going through the flow cell, and the machine saying you're going to get a high MCV. Make sure they make sense. But how do you know that it makes sense or not? Make sure you look at the MCHC. If the MCHC is between 32 and 36, then it's legitimate. Okay, then it's legitimate. If the MC is not, if it's super sky high, then chances are that CBC is not reportable. Look at the I'm telling you, look at the MCHC first to determine whether or not, I think I'll put it on a quiz. Tell me which is acceptable and tell me which is not. The first thing you should look at is the MCHC. If you're reporting something with an MCHC of 45 and you're in your clinical rotation, I think the CLS is not going to be too happy with you. Okay, so anemia. Anemia, the RBC count is low, so is the H and H. WBCs and platelets may decrease. Peripheral blood, okay, peripheral blood is pancytopenic. It may be, okay, it may be pancytopenic. But what I want you guys to know, if you see pancytopenia, what type of anemia should you be thinking about?
Aplastic anemia.
Correct. Aplastic anemia. Okay, so I have pancytopenic there. That's as a coincidence, or it's a probability. It may be pancytopenic. For megaloblastic, the key things are normochromic macrocytic. These two things here, normochromic macrocytic MCV greater than 100. Don't worry about the pancytopenic. Well, he said, in lecture 8 that if you see pancytopenia, then it's B12 folate deficiency. I want you to remember that pancytopenia is aplastic anemia. Also, too, with this type of anemia, the red blood cells, keep in mind, the red blood cells are sick. They're sick because of the defect, the nuclear cytoplasm asynchrony. Survival time is 27 to 75, as opposed to the 120-day survival time. Okay, these cells are short-lived. They're shorter-lived. They won't last as long. So 27 to 75 days, as opposed to the normal 120 days. So other conditions that can cause megaloblastic RBCs are alcoholism and liver disease. Okay, where do you get your B12 folate? Where do you get your vitamin B12 from? Make sure you know this. Vitamin B12 comes from these sources: meat, and dairy products, eggs and dairy products, okay? But mainly it's of animal origin. If I give you a question, it's gonna be a meat. And then if I put which of these do not belong, I'm gonna give you liver, fish, celery, chicken, and beef. Which one doesn't belong? Well, the celery doesn't belong. If it's meat origin, that's where you get your vitamin B12, okay? That's where you get your vitamin B12. It's from the meat and dairy products. I'm kind of staying away from the eggs and dairy products because this can also be present in folic acid. Folic acid can also be in here too, but primarily if it's meat or animal origin, that's where you get your vitamin B12. Vitamin requirements increase with pregnancy. If you are pregnant, then you need more vitamin B12. That's why I guess that's why they give you the prenatal pills. Vitamin B12 is lost in the urine and the feces at a rate of 0.1% per day. Excuse me. And body storage is about 1 to 5 milligrams. And I'll do a comparison with folic acid later on. Daily requirement is low, and the storage rate is high. So you store vitamin B12. So since you have a high storage rate of vitamin B12, that means it'll take a long time for you have to work really, really hard to be vitamin B12 deficient, okay? Because you have a lot in storage. The storage rate is high for vitamin B12. Also, too, the dietary requirement, the needs will increase with pregnancy and infancy. Pregnancy, because now you're feeding for 2 people, and infancy because they are in development. Daily requirement is approximately 5 to 30 micrograms, and I'll show that comparison when we do folic acid. Okay, vitamin B12 deficiency is not common in Western cultures. Why? Because we eat a lot of meat. Western cultures eat a lot of meat. There's vegans and vegetarians, but for the most part, everybody eats meat. So not too many people will be vitamin deficient, okay? And it's usually limited to strict vegetarians. Children who are born to vegan mothers are almost always B12 deficient. And these children, who don't get their B12, untreated infants will suffer from retarded growth and psychomotor development. The reflexes will not be where they should be, and they won't grow to a height where they should be. Anorexia, they'll suffer from anorexia. They're irritable, and they have that condition, failure to thrive. Okay, so you need to know this chart. Okay, this is a very important chart. Okay, this is where you get your B12. You get it from the meat source. B12 comes from here. And on this side here, you have your stomach. And inside the stomach, you have cells called parietal cells. I'll show you the spelling later, parietal cells. And the parietal cells will produce what's called intrinsic factor. So B12 here, intrinsic factor here. So you eat some fish, it goes to your stomach, and what happens is your B12 and the intrinsic factor will form a complex. It will form a complex, the B12 intrinsic factor complex. They'll bind to each other, okay? B12 folate and B12 and intrinsic factor will form a complex. Okay, so it goes from the stomach and it goes down to your intestine. Now, in the intestine, in the ileum, which is the last part of the small intestine, now you're in the ileum, something will happen. This B12 will come off of the complex. Well, this will uncomplex each other. The B12 will bind to TC2, which is transcobalamin 2. Okay, transcobalamin 2. When it binds to transcobalamin 2, that means it's ready to go into the circulation. It needs to bind to transcobalamin 2 before it goes out here. What happens to the intrinsic factor? It gets absorbed into the ileum. Okay, so it goes from intrinsic factor from the stomach, B12 from the meat source, forms a complex. It goes through the digestive system. When it gets to the small intestine and the ileum, B12 will come off and bind to transcobalamin 2, and the intrinsic factor will bind to be absorbed by the ileum. So now you have this B12 transcobalamin 2 complex. This is what gets circulated out into your circulatory system, and this is how the B12 gets to your bone, your liver, and other tissues. Okay, so that's how you absorb vitamin B12. So there are ways to, you can see that there are ways to become vitamin B12 deficient. One, if you don't have the source. If you don't consume vitamin B12, of course, you're gonna be vitamin B12 deficient. Or if you consume vitamin B12 and you're not getting any B12 here, that's a good sign that you probably have a parasitic infection. Because if you're consuming it and you have your intrinsic factor here, you're consuming meat, but then it's not binding to any B12 from the meat that you're consuming, then that's a good sign that you have a parasitic infection. Another way that you can be B12 deficient is if you have a problem with the stomach. Let's X this out. You have a problem with the stomach, what are you missing? You're missing intrinsic factor, okay? So you have vitamin B12, but it's not binding to intrinsic factor, so then it's not gonna go down to your ileum, no intrinsic factor to come off of, and then none of your vitamin B12 is gonna get bound and circulating to these sources. So no B12 source, no intrinsic factor source. You can also have a problem with transcobalamin 2. If you don't have transcobalamin 2, then vitamin B12 here and transcobalamin will not bind and get into your circulation to arrive at these three sources here. So there's different ways, and I'll explain that to you when I discuss these different conditions on how you can become vitamin B12 deficient. No B12, no intrinsic factor, or no transcobalamin 2. Okay, if you don't have any of those, you're going to be vitamin B12 deficient. So no B12 consumption, be like vegetarian, for example. All right, so make sure you know this chart. In the ileum, B12 comes off, intrinsic factor comes off, B12 comes off and binds transcobalamin 2. Okay, so make sure you know that. So this is the description. B12 comes from food. Intrinsic factor comes from the stomach parietal cells. Then the B12 intrinsic factor complex is formed, and the B12, in order for the B12 to be absorbed into the ileum, it must attach to intrinsic factor. Okay, so you have that complex. Okay, to enter, so it has to be a complex to enter the ileum. Okay, so what will happen is the B12, like I said, the B12 will come off and combine with transcobalamin 2, and the intrinsic factor will be absorbed into the ileum. So once in the ileum, B12 is transported into circulation, but it's B12 transcobalamin 2. Once in the intrinsic factor is replaced by transcobalamin 2, that actual replacement takes place in the ileum. And once it's paired, this pair here, B12 transcobalamin 2, that's its ticket to enter into the circulation. Okay, because intrinsic factor left and has gone into the ileum, and B12 is now prepared to enter the circulation as this complex. Okay, once it's in this complex, then it goes to the liver, bone, etc., and other tissues, bone, liver, and other tissues. B12 deficiency can arise due to hereditary defects in transcobalamin 2. So if you have a problem with transcobalamin 2, then you can become B12 deficient, and you can see that. So if you don't have transcobalamin 2, that's how it has to be in this complex to be delivered to the bone, liver, and other tissues. Okay, so problem with transcobalamin 2. For pernicious anemia, the most common cause, that's the most common cause of vitamin B12 deficiency. Pernicious anemia is the most common cause of vitamin B12. It's a chronic disease caused by a deficiency of the intrinsic factor. So where does the intrinsic factor come from? It comes from the stomach. So if you have a problem with your stomach, you're not producing intrinsic factor, you're going to be vitamin B12 deficient. Therefore, that's going to cause a pernicious anemia. Okay. The result is defective absorption of vitamin B12. Obviously, because intrinsic factor is either broken or absent and will not bind, nothing will bind to vitamin B12. You won't form that B12 IF complex. Pernicious anemia is common in people in the Scandinavian countries. And it's rarely in children, usually adults, and it's seen in women 4 times more than in men. And the age group is after 50 years old. This is pernicious anemia, Scandinavians, adults greater than 50 years of age. And it starts for Blacks to have pernicious anemia, it starts at an earlier age. Okay, but in Scandinavia, it's 50 years of age. The congenital form, that means if you're born with this condition, it's seen in children before the age of 2. And what happens is it's an autoantibodies. The serum of patients contain autoantibodies to the parietal cells, and that's possible. You can have antibodies to the parietal cells in the stomach, and to the intrinsic factor, and to thyroid tissues. If you have antibodies, an autoimmune disease that attacks the parietal cells, or especially your intrinsic factor, it's going to create, obviously, pernicious anemia. Because if you don't have intrinsic factor, then you won't have the vitamin B12 intrinsic factor complex and go through the cycle. Okay, so that's where autoantibodies will attack here. Okay, if you have something attacking your stomach or intrinsic factor, you're going to get pernicious anemia. All right, antibodies to parietal cells. Okay, so you can have antibodies to the parietal cells or antibodies to intrinsic factor. So antibodies to the parietal cells happens in 80 to 90% of the patients. That's the more common antibodies. And then antibodies to intrinsic factor itself is seen in 50 to 70%. So either way, you're going to be vitamin B12 deficient, but the more common one is antibodies to the parietal cells. Neurological problems are common in pernicious anemia than any other types of B12 deficiencies. Okay, so if you have pernicious anemia, you see these autoantibodies, then you're going to get, it's more common. You'll get neurological problems. All right, the parasite, you're going to learn this next semester. The parasite is D-latum. You won't Diphyllobothrium latum. Okay, you're going to learn about this in micro. And it's the fish tapeworm. What happens is it latches onto your gut, and what it latches on, and what it does, it intercepts the vitamin B12. It's actually competing with you for the vitamin B12 that you're consuming. So you go ahead and eat your steak dinner, or you have your fried chicken or whatever. You take in your vitamin B12, and you kind of want to, I'm feeling tired, and then your doctor says, well, you're vitamin B12 deficiency, but vitamin B12 deficient. But I'm taking in, and my diet contains a lot of vitamin B12, but that's due to that parasite that's taken up your vitamin B12. There's another way to determine that you have a parasitic infection. One way you can detect that if you have a parasitic infection like a worm like this is that eosinophils will be increased. Whenever you have eosinophils increased, maybe like 10, 15 in that range, then you can suspect, and you don't have asthma or anything, you can suspect that you have a parasitic infection. Okay, I'll get into that when we talk about eosinophils in the myeloid lecture. Okay, so the parasitic infection cause of vitamin B12 deficiency, again, is common in Scandinavian countries. So in reading this, I'm looking at ways where I can create a case study. Like I can say a 33-year-old or I should say a 57-year-old Scandinavian woman had a doctor's appointment complaining of being tired, and turns out that doctor ran a B12 level, and she was deficient. And then I'm going to give you guys some labs, and you guys are going to figure out what's going on with this lady. Okay, so that would be like a typical case study. That's the worm. That's the scolex, which is the head, and this is rostulum, where it actually bites on, and these are actually suckers right here. It'll suck onto the gut, and it'll also bite onto the gut. And this is the proglottid, where these are uterine branches, reproductive system of the worm. And this is the egg, D-latum. This is a D-latum egg. At the end of this course, you'll know next semester, you'll know how to identify these eggs. Okay, folate or folic acid. Okay, remember folate is the conjugate base of the acid folic acid. It's also known as pteroyl glutamic acid. Okay, and this is present in leafy green vegetables, fruits, dairy products. See, dairy products, that's also B12, right? Dairy products is a source of B12, and cereals, but mainly green leafy vegetables and fruits. So I can say kiwi fruit, kale, lettuce, carrots, not carrots, but lettuce and cabbage. Green leafy vegetables. Average diet contains 400 to 600 micrograms, but is heat labile, meaning that in the presence of heat, it'll break down. That's why you don't want to cook your vegetables. That's why you don't want to cook your vegetables too hot, because this is what's going to be degraded. It's the folic acid. It's heat labile. Okay, that's why you don't want to cook your vegetables too hot. Recommended dietary intake. Recommended dietary intake for folic acid is 50 to 100, but for B12, the recommended dietary intake is only 5 to 30 micrograms. And the storage of folic acid is 5 to 10 milligrams. The storage for vitamin B12 is 1 to 5 milligrams. Folate has a higher turnover and higher loss compared to vitamin B12. So because you're turning it over, that's why you have a higher recommendation for dietary intake. You turn it over faster, and it only takes only a few months to develop deficiency. Whereas remember, in B12, it's hard to become vitamin B12 deficient. The main cause of folic acid deficiency is decreased dietary intake. That's why you need to eat your green leafy vegetables. Malabsorption, increased requirement, and drug-induced folic acid deficiency. It's another reason why you can be deficient in folic acid. It is a megaloblastic anemia. Remember, vitamin B12, they go hand in hand. So in the laboratory, the blood film will look exactly the same. Vitamin B12 and folic acid deficiency, there's no morphological distinction. You'll see hypersegmented neutrophils and you'll see oval macrocytes. Hypersegmented neutrophils and oval macrocytes. Anisone point, again, it's not red. I'll reserve the significance of anisone point for iron deficiency anemia. Hypersegmented neutrophils, that's what you should see. And these findings are characteristic of megaloblastic anemia. Hypersex right there. Hypersegmented neutrophil. Laboratory tests doing a serum B12 and serum folate level. Normal values are 200 to 500. Folic is 5 to 16. It's not red because I'm going to reserve those values for your chemistry class. So there's ways to determine if you have your the cause of your vitamin B12 deficiency, whether or not you have a problem with transcobalamin 2 or a problem with intrinsic factor. For transcobalamin, you can rule it out by doing radioactive B12. It's called the Schilling's test. And then for intrinsic factor, that will rule out testing for also in conjunction with the radioactive label. If it goes through and the intrinsic factor is not there, and you don't get vitamin B12, then that can help you diagnose celiac disease, malabsorption, tapeworm infection, which is a parasite, and bacterial overgrowth. If you want to know more about the Schilling test, here's the link here. So I'm going to invite you guys to look at the link. The Schilling's test is not done very often. When I was training, we did a Schilling's test, and it was kind of a long test. But if you want to know more about the Schilling's test to help diagnose vitamin B12 deficiency, then I'm inviting you to open that link. So how do you treat it? Usually for vitamin B12 deficiency, you can take the pills or you can get a shot. Vitamin B12 intramuscular, IM is intramuscular. Folic acid deficiency, folic acid orally, eat your vegetables, or you can get injections as an inpatient. All right, and that is megaloblastic anemia. Are there any questions? Any questions? All right.